So Professor Duckett, I guess, I mean, you're clearly a very prominent health economist. You know, you've got a long track record in the healthcare space, having run, effectively run the department, the previous Commonwealth Department of Health in the past. And as I mentioned earlier, you've been at the Grattan Institute for the last 10 years. You've just joined the Medicare task force, the strengthening Medicare task force that was put together to help Mark Butler, our health minister, actually spend $750 million apparently to improve access to healthcare and deal with chronic disease and affordability issues. Can you tell us a little bit more about what you're seeing, in that task force? I guess it's meant to be something that is helping to try and fix some of the issues that people are already identifying as problems in Medicare. But have you actually got any sort of insights that you can share with the people on the call?
Well, obviously, I can't talk about precisely what's happening in the task force,
yeah.
But the issues considered by the task force or being considered by the task force are the same issues that you're actually seeing in this survey and the same issues that we've talked about for a while. I just want to pick up on something that Kylie said about workforce. We used to have an agency in Australia called Health Workforce Australia, which was an agency set up to bring the Commonwealth and the states together and to actually focus on health workforce planning. That was abolished in Peter Dutton's budget, 2014 budget, when he was health minister. So it's interesting to me, how long does it take, once you abolish Australia's capacity for health workforce planning, how long does it take to see the problems emerge? Well, they've probably been emerged a little while ago, but certainly after 8 years of effectively no workforce planning in Australia, surprise, surprise, we've got health workforce problems. So we shouldn't imagine that these issues are things we can't deal with. We actually had mechanisms to deal with in the past. We don't have mechanisms now. And some of the solutions are of the kind that Kylie talked about. The second point I want to raise is the survey that is being released, the healthcare index, is really quite interesting, because one of the questions was, why did you give this such a high rating? And one of the questions was, why did you give it such a low rating? And so when you look at that, the people who rated healthcare 9 or 10, really, really good, said good access, good quality of care. People who rated it really, really low said poor access, poor quality of care. So the experience of people is very, very different. Now, we don't know from what you've given us whether that experience of care is geographically determined, whether that, and I suspect there's a bit of a rural-urban problem here, whether it's income determined, socioeconomic status determined, wealthy people have better access than poorer people. But so what we know is Australia is providing good care for some, it's just not providing good care and good access for all. So that means there's an agenda, we know what to do, it's just we're not doing it everywhere for everyone. I'd just like to pick up on the bulk billing issue, which is really important. Over this year, 2022, the rate of bulk billing for general practice has declined from about 88, 89% to about 84%. So a significant decline in bulk billing. So obviously that is something that government has to address. It is going to cost, I think, way, way more than the money available in that 750, which is really 250 million a year. But it's obviously something government has to address. And the real issue is how you're going to do that. The second issue is the workforce issue. And obviously, again, part of that has to be other people doing things that GPs used to do. So, for example, I've got a friend in England who had a pain in his low back. He rang up his general practice and said, I've got pain in my low back. And they said, thanks very much, we'll let you know. And a physio rang him back. Part of the general practice, employed in the general practice, was a physio who dealt with musculoskeletal issues. So not some sort of separate deal, not sort of undermining general practice, but actually incorporated into the general practice. So these are the sorts of things we've got to be talking about. These are the sorts of solutions for the future in Australia. People who are skilled, as Kylie said, people who are skilled in, we're not talking about second-rate care, we're talking about people who are trained to deal with some of these issues, actually dealing with them. So we've got to actually design the financial incentives and the system to make this work, and it doesn't work at the moment.